Muy buenos días para todos y todas y bienvenidos a la sesión de hoy.
Good morning, everyone, and welcome to today's session. My name is Hernan Rodriguez. I'm counselor for systems and healthcare services from the PAHO representation, WHO representation in Peru, and I will be with you for these following 2 hours as part of this webinar. This is the third webinar on a series on policy options to strengthen and transform healthcare systems in the Americas for PAHO. And those who have participated in the previous sessions are already familiar with our dynamics. The series has had a very special attendance from participants from more than 40 countries in each of the sessions, and today is no exception. Today we have more than 300 participants, and we are sure that this figure will grow in the following minutes. At this time and this opportunity, and as we also did in 2021, we will address a central point for the strategic agenda to attain universal health, challenges in access. We have entitled this webinar, How the Healthcare Reform Impacts Access Barriers. Are our healthcare systems prepared to advance toward resiliency and universal access? And we have invited a set of distinguished panelists whom we will be introducing timely. Before beginning, I would like to tell you that we have simultaneous interpretation in our four official languages of the organization: English, Spanish, Portuguese, and French. Please pick the appropriate language for your convenience. To select the language, you must press the globe icon in the lower part of your Zoom screen. We also remind you to adjust your video configuration on Zoom to side-by-side mode. That way we can all see in the same screen both presentations and speakers. Please note that you may put forth your remarks at any point during the seminar via the chat and your questions via the Q&A option, the Q&A letters on your screen. And lastly, we kindly ask all of our panelists to please stick to the minutes that you have assigned for your presentation. Once you are over your time, we will let you know in order for you to finish or cap your presentation. We also remind you to please keep your microphones off to facilitate the development of this seminar. Now, to begin the seminar, I have the pleasure to give way to Piedad Huerta, representative of PAHO WHO in Honduras, a citizen from Mexico. She is a graduate in journalism and with a master's in public health from the Autonomous University of Ciudad Juarez. She has a long professional journey in public health and the organization, which run from bordered healthcare in the old field office on the US-Mexico border up until her duties as main counselor for the directive office. Welcome, Piedad, and thank you so much for accepting our invitation. Thank you so much, Hernan. It is a great pleasure for me to be at this very important seminar. Good morning, welcome everyone. Now, for my duties as representative of the country office in Honduras, really the vision on these barriers is much closer than in previous iterations. It is a pleasure for PAHO to have this excellent group of experts in order to exchange experiences and reflections on one of the main challenges in the region, reducing and removing access barriers to healthcare services. This is why the driving question for the seminar is fundamental. Are our healthcare systems prepared to advance toward resiliency and universal access? From the beginning of this cycle, the organization has promoted a comprehensive vision to policy options and the journeys to transform and strengthen healthcare systems. We have done this supported on mandates that our member states have provided us and based on commitments that the region has assumed, such as strengthening primary healthcare attention. These efforts have required work from all levels of the organization, and in particular from articulation and cooperation technically at the country level. As representative of the organization in Honduras, I can provide an account that joint efforts and collaboration with the Healthcare Secretariat has been key to transform the analysis of access barriers into a key input for seeking policy options which allow to strengthen the healthcare system and decision making. Today, we'll have the chance to know many of these working processes in the countries, their results, and especially their reflections with regards to the future in the system, because is still much yet to be done. And as we stated in the calling to this webinar, before the COVID-19 pandemic, around a third of the population in the Americas region ha had experienced unsatisfied needs with regards to healthcare attention, highlighting many types of barriers, for instance, institutional ones, cultural, linguistic, organizational, physical, financial, behavioral, among others. And these barriers have deepened without a doubt after the COVID-19 pandemic, its impact in essential healthcare services continuity, as well as measures adopted to reduce mobility and exposition to people, especially during the strongest times or hardest times of the pandemic. Then we have the need to double down efforts in the region in order to attain the goal that has been assumed in Pact 30-30-30 APS for universal healthcare in transforming healthcare services by 2030, orchestrating efforts to remove access barriers at least in 30%, to increase public funding in healthcare at least into 6% of the GDP, and to invest at least 30% of this public funding in primary healthcare attention. The organization has some key tools for working with member states and along these lines, a strategy for universal access to healthcare and universal healthcare coverage approved in 2014, which emphasizes the need to ensure access and therefore to remove barriers that the population is facing in order to access healthcare services when they need it, and also a strategy to establish healthcare systems that are resilient and recovery in the post-pandemic stage in order to uphold and maintain achievements in public healthcare, and the strategy approved in 2020, which is fundamental as a roadmap that is updated to the new challenges that the pandemic is leaving. Based on these mandates and challenges to access that the many persistent barriers represent in the region, PAHO has oriented its technical capacities to support countries on many aspects in the development of tools or instruments to characterize the scope and types of access barriers and understanding how these manifest in the many territories and how they affect differently according to age, gender, and ethnicity, as well as the prior healthcare condition of people, and especially how it affects groups in greater situation of vulnerability, indigenous peoples and native peoples in the region, Afro-descendants, children, adolescents, youths, women, LGBT individuals, among others, and understanding how policy and reform initiatives in healthcare systems have modified the conditions in access, and especially strengthening through this analysis and reflection the design of policies which keep much in mind inequalities and limits upon exerting the right to healthcare that these barriers generate. Definitely reducing and eliminating access barriers is a necessary condition to attain universal healthcare. These are just some introductory notes for developing this activity, which will really be in the input and experiences that will be shared next by our guests. Thank you so much, everyone, for participating in this webinar and as to not leave anyone behind.
Muchas gracias, Piedad, por tu
Thank you so much,
intervención.
Piedad, for your intervention
La verdad,
and your reflection.
agradecemos.
Really very important. We think
Para
those
nuestra
words
sección de
to
presentación de
open up
experiencias de
our
país, hemos invitado
session
al
for
doctor
presenting country experiences. We
David
have
Barde,
invited Dr.
investigador
David
de la
Barde,
Universidad de Los Andes,
researcher
Colombia,
from the Los Andes
para
University,
que en su
Colombia,
presentación
so
sobre
he
la
may share a
experiencia
presentation
nacional
on
de
the
educación
experience of the
superior en
mandatory
salud en
plan
el abordaje de la
for
atención de
healthcare
acceso
in
a los
addressing
servicios de
access
salud.
barriers to healthcare
David
services.
tiene un doctorado en
David
economía y
has a master's
administración
in
de la
economy. He is a
Región de la
professor
Universidad
at
de
the
Los Andes,
Economy School of the Los Andes
profesor
University
asociado
and
de la Escuela
associated
Superior de
researcher to
Investigadores
Toulouse School of
sobre
Economics.
temas de economía
He works
pública,
on issues of
economía
public
de salud,
policy,
de protección
healthcare,
social, de organización
economics,
industrial y
social
de
protection, or
regulación.
industrial
Ha
organization and
sido
regulation.
consultor para el
He has
Banco
been
Mundial,
consultant for the World Bank,
OND,
the
CEPAL,
IBD,
el
UNDP,
Ministerio de
CEPAL,
Salud y
and the
Protección
Ministry of
Social
Healthcare
en
and
Colombia,
Social Protection in
la
Colombia,
Superintendencia de Salud
the
y
Superintendency of
PDS.
Healthcare, and
Acaba
PAHO.
de terminar un trabajo sobre el
He's just
problema del
finished
acceso a
efforts
programas
on
de
access
protección
problems with
social
Angela
en
Rosero and
Colombia
healthcare systems in
y
Colombia
de República Dominicana.
and in the
Bienvenido,
Dominican
David.
Republic. Welcome, David. Go ahead.
Muchas gracias, Hernán, por
Thank
esta
you so much,
presentación
Hernan.
y muchas gracias también a Natalia, Ernesto
Thank you to
y
Tommy,
Andrés
Natalia, Ernesto,
por
and
la
Andres
invitación.
for the invitation.
Voy a,
I am going,
yo estoy haciendo la presentación
I'm going to make the
de un
presentation,
trabajo que hicimos con Ángela
which comes
Posero
from
en
something we did
2006.
with Angela Posero.
Entonces,
So
la hago a nombre de los dos.
on behalf of the two,
Esta presentación viene
and this
en
presentation
un
comes,
contexto
as Hernan
de un
stated,
trabajo que
in a
hicimos para
situation of an
PDS,
effort that we carried out for PAHO,
Colombia y
for
República
Colombia,
Dominicana. Acá
and
nos
the
vamos a
Dominican
concentrar
Republic.
sobre
So here we will
Colombia.
focus on,
Voy a empezar con
I'm going to
una
begin
gráfica que seguramente
with a
muchos
chart that
de
surely
vosotros
many of you already
conocen,
know.
que viene de la Organización Mundial
This
de la
comes
Salud,
from
que
the
tiene tres
World Health
dimensiones,
Organization,
tiene de la cobertura.
which
¿Por qué tres dimensiones? Porque
deals with coverage
necesitamos
in 3
saber
dimensions.
de cuántas
And this is
por ciento de la
because
población cubierta
we need to know the
existe.
percentage of
Aquí en
covered
Colombia pueden ver que estamos muy
population.
cerca de la
In the country. In Colombia, you see that we are very
casi
close.
el 98% de la población
More than
cubierta.
98% of the
Debemos
population is
saber
covered. Another
cuántos
dimension is to know
cubiertos
that
hay,
when we
cuál es
have
la
this
proporción de
population covered, what is the
esta dimensión.
proportion of total
Y acá
health
en
expenditure?
Colombia, como lo veremos
And
en
here
la
in
siguiente
Colombia,
diapositiva,
as we will see in the next slide,
un vacío
we
bastante
have some
moderado.
out-of-pocket expenditure that are moderate. And
¿Cuáles son
finally,
los
what
servicios
are
y
the
tratamientos de salud
services
cubiertos?
of health departments that are covered
Adentro, el paquete al cual
in the
los
package
usuarios
where
tienen acceso.
users
Acá es
have
mucho más
access
difícil de
to?
dar una
Here
cifra
is more
cuantitativa
difficult to
porque esto
provide
viene
quantitative
diariamente,
information.
se
The
actualiza
health
bastante
plan is updated on a regular basis
varias
in
ocasiones.
many
Y además,
situations.
creo que las autoridades en Colombia se han
And authorities in Colombia have realized that treatments are more expensive when they are outside in comparison when they are already included in this health service plan. Now let's see Colombia in comparison with other countries in the region. What we can highlight here is that Colombia is doing a very significant effort in terms of the public health expenditure. It is higher in comparison to the rest of the countries in the region. And this goes together with the right, they want to reduce private expenditure And here you can see that out-of-pocket health expenditure in Colombia is below the average expenditure in the region.
Como lo dijo,
However, as I said,
hay que ver que esta cobertura
this coverage
es una condición necesaria para
is a necessary condition
acceso efectivo.
to have an effective access to health services. And here we can see that
Está lejos de ser perfecto cuando miramos
we can still be
los temas
eh,
del lado de la oferta.
improved in terms of the supply and demand, in terms of physicians for 10,000
En términos de
inhabitants. Colombia is a little bit below the average, and the gap is higher here. In terms of beds, hospital beds is worse. Then here we can say that the coverage will involve to have reduced out-of-pocket health expenditure to protect users and also to protect health services expenditures to have an effective access. And we need to take care of the supply and demand, taking into account these indicators of medical, of physicians and hospital beds. Here we can now going to see some figures related to the percentage of the population who are not seeking care. And we are going to see where problems come from in terms of access. In fact, here you can see that since 2003 to 2019, 2021, there are many people with access who are not seeking care when they need it. And to your right, you can see in more detail why. Usually, as we understand this data, and this is shown by these different percentages, some of them think that symptoms are mild, or some others are self-medicated, some others have home remedies. And we can see here the social and economic motives in Colombia. Colombia has a lot of inequality, and you can see this in many academic references. This information in terms of gap is very important, and this is also translated into this information to explain the effective access of people. If we see in more detail the financial barriers, what we can see here is that with the universality that Colombia achieved, we have the lack of money, 12% in 2003, and 2.1% in 2019, 2021. And this shows that people is already protected in terms of financial access, in terms of the financial problems involved in health problems, but not everything is solved. We still need to solve some long distance problems. Colombia is a nice country, but it has a complex geography, and there are many remote areas where access is limited. Another issue that we will see later is related to the waiting times and the paperwork. And here I'm going also to show some social and economic inequality problems, not only financial problems. When we have a lot of paperwork to solve, to have effective access to health services and treatments, the education level is very important to explain the access. This means that more educated people are going to be able to navigate better through these health services. And then I can take a lot time to explain this slide, but we wanted to explain here in an easier manner for you to read it at home. Here you can see the explanation of the different access barriers, organizational access, contact, geographical access, availability, some other financial aspects, acceptability aspects, and also some cultural aspects that are also important to understand the effective coverage. I'm going to summarize these different items that we can see in this table. This comes from the references that we have reviewed in Colombia and the work that we were doing with Natalia, Ernesto, Andres, and Angela for PAJO. We had many interviews to collect information that is interesting to understand the access barriers. I'm going to try and summarize these barriers. There are different bottlenecks that reduce effective access. Colombia is a system that we can call managed care competition. EPS are the health promoting entities, are the gateway to the system, and we have the state that assign the health promoting entities the role to organize the expense of access to negotiate the tariffs with the different providers. And then they receive a unit. It doesn't depend on the quality of services. They should normally fulfill two functions: to offer quality services. The problem is that this is an exclusive competence among countries, and we as users, is a competition among countries, and we need to measure. And these entities, they don't feel a strong pressure to compete, and they receive a payment, and the only reason, a low payment, the only reason to maintain health services are aligned incentives to control the expenditure. Health promoted entities are doing a good work in terms of the containment of expenditure at the expense of access. Sometimes it is also at the expense of the quality of services that are provided, and they can also have incentives or problems related to access that are also seen with the paperwork to be submitted. As I already mentioned, there is also a socio-economic inequality to overcome these limitations related to the paperwork for low-income people compared to the others. Although it is, in theory, an equal service, in practice, we have many gaps and bottlenecks according to the level of income of the population. We have also incentives to control the expenditure. This is also at the expense of quality, and these health promoting entities and some health service providers depend on the quality of services. Sometimes there are clinics, hospitals that show some quality indicators, but they are not common in terms of their agreement. Another problem that we see in terms of access is the very unequal supply between urban and rural areas. In rural areas, in remote areas, where we see extreme precariousness. I had done a work in the Amazon department in Colombia, where we usually don't have hospitals or health units. We only have some health centers with irregular presence of physicians. So we also have some other regional differences in terms of infrastructure. Hernan, you wanted to intervene. Herman, your time is over, but we are going to give you one additional minute to finish your presentation. Okay, thank you. In terms of the information systems, they are not unified in the health system. We don't have interoperability of information, which is a problem for transfer information, for detecting corruption by stakeholders. And another problem, another bottleneck that we see is the low supply of some drugs. We still don't know what are the reasons. We have many assumptions. Maybe we had some strict conditions for the distribution of some drugs. Or maybe
hay cuellos de botella acá también. Ahora, rápidamente, unas recomendaciones que podemos hacer sobre esto. Primero,
regarding this, which pertains to the Ministry of Healthcare on governalizing control and having an information system that is robust and unified among all stakeholders, as it will be always very difficult to detect abnormal behaviors in these conditions, improve availability of conditions to resources, especially labor conditions for healthcare workers, which in Colombia are not good. There are problems, access issues for many specialists and subspecialists. Often one may blame their insurer for not being able to access specialists on time. But actually the issue here stems from the way in which specialists are determined in Colombia, which is sort of like a cartel, and it is very difficult to change and to have a more robust in remote coverage in remote areas in order to have effective access. Another recommendation that we have is for there to be much more payments associated to quality, especially at the level of those who receive the EPS. Currently, an EPS which offers healthcare services that are good or bad receive the same EPS, which implies perverse subsidies. They would have to be conditioned per quality indicators. And just to finish, Hernan, I would like to bring to you a debate that we currently have at Colombia regarding the role of intermediation or mediation. There are critics criticisms regarding the role of EPSs, as we have that this builds circles, perverse circles that are detriment to quality. There are EPSs that are concentrated in containing financial risk, which is important but not sufficient. And also we have blamed the EPSs for factors that they cannot act upon, as they are not responsible for limitations at the level of supply, rural areas, and they are not responsible for a lack of an information system that would allow better information and better supervision. In any case, what I wanted to highlight, and I will finish here, is that the Colombian healthcare system, that is public or private, it needs to have one or more intelligent buyers. Regarding the reform that has been socialized somewhat by the Ministry of Healthcare in Colombia, it is talked of insurance, which can be complicated without at least having an information system. So in other words, currently the Colombian state delegates the role of smart buyer to companies. In order for this to be substituted into this role of smart buyer, at least we need an information system that is very robust, and that takes time. So here we are not advocating for a public or private system. We are just saying, if we want a public system one day in Colombia, there are some necessary conditions regarding that information system, because regulating all healthcare rates in the system from the ministry is something very complex. And actually, I know this by my experience in France. On rate regulation is very difficult, and it requires an information system that is very important. So we're not defending one system over another here, just commenting on the conditions that we need. And any healthcare system requires a buyer or many, but nobody to be hurt by expenditures. So in the end, there is problems in access due to a lack of sustainability of the system. Thank you so much. And thank you so much for your time. Thank you, David, for your presentation and information, really very relevant. For example, on how Colombia has been increasing its percentage of public expenditure, approaching the regional goal of 6% with regards to GDP, and also a very representative split regarding out-of-pocket expenditure. But your presentation surely opens up any questions, and so we will wait for later on. So once again, thank you. We remind all those online that you can leave your questions via the Q&A option, where you see the Q&A letters on your screen, and upon closing the session, we'll have space for our guests to comment and respond. In order to share another experience on application of instruments for analysis of barriers to access barriers, we have also invited our colleague, counselor on healthcare systems and services from the PAHO WHO representation to Suriname, Dr. Rosemond Adams, a native from San Vicente and the Grenadines. He's a doctor in medicine and a master's in science, public health care, and bioethics. In his career, he has gone through many duties in the Ministry of Healthcare in his country, CAFA, the Caribbean Public Healthcare Agency, the Pan-American Alliance Against HIV/AIDS, that he has served as director for, and more recently in PAHO. Thank you for accepting our invitation, Rosemond. Welcome, and go ahead.
Thank you very much, Edman. Good morning to everyone. And let me start by saying thanks to facilitators for inviting Suriname to be part of this important discussion and this important dialogue on barrier to access. I'll start by saying that even as we focus on the COVID-19 pandemic, even before COVID-19, the health system in Suriname did face a number of challenges, significant challenges with respect to access, and COVID-19 only served to exacerbate these barriers and even highlight new gaps in access to care. I'll start my presentation by giving you an overview on Suriname. Suriname is a country that is located on the northeastern Atlantic coast of South America. It borders French Guiana to the right, English Guiana to the left, and Brazil to the south. There are 10 administrative divisions, and it is divided into 62 resorts. Most of the people in Suriname live on the coastal area, and there is a small proportion of the population that lives in the interior of Suriname, and the official language is Dutch. In terms of the health system's context, the Ministry of Health is not a provider of services, and so there are three main providers of services in Suriname. Along the coastal area of Suriname, that is the area that is highlighted in orange, the RGD, or the Regional Health Services, do offer care to this small region, but it is a region that is mostly populated in Suriname, and they offer public health and curative care and have a network of approximately 63 clinics. In the interior of Suriname, the region that we call the interior of Suriname, which is the area that is highlighted in yellow, the medical mission, that is a non-governmental organization but is subsidized by the government of Suriname, do offer healthcare through a network of about 52 clinics. And there are also a number of private physicians, approximately 200, and all of these are supported overall by a total of 7 hospitals in the country. Suriname has been seeing an ongoing demographic transition. If you look at the population pyramid from 1980 to current, you can see that the population pyramid has been changing, with an internal migration trend towards urban areas, and a lot of the population is currently living in Paramaribo and other urban areas in the country, and an immigration trend. The total population of Suriname is approximately 598,000, with an annual growth rate of 1.34, life expectancy of 71.7 years, bit higher for females, 75 years, and men, 68 years. Literacy rate of 95%, fertility rate of 2.2 births per woman, and a GDP of approximately, in current US dollars, of 4,916, and the public health expenditure per capita in current US dollars, 474.13. Suriname has been going through a number of reform in terms of the health sector, and in 2014, Suriname implemented the basic health insurance, and in 2026, the basic health insurance that is called the SZF, which is the national fund for the Surinamese population, came into effect in 2016, and they do cover approximately 70% of the population, but there is still a large proportion, significant proportion of the population that is uncovered, especially those people who live in the interior of Suriname. And when we look at migrants who are not documented, they still do not receive access, and so this population do have challenges in accessing health services. We did conduct the STEP survey in 2013 in Suriname, and we look at data in terms of people who needed medical care and did not receive it for reasons related to organizational accessibility. And what this pie chart is showing are some of the areas that people reported on that were barriers to access to care. If you look at the pie chart, approximately 48% said that that the waiting period was too long in terms of having to wait to see a physician or skilled medical personnel. And then there were, you know, a long waiting list. 12% of them from getting an appointment until the actual procedure, the list was too long, and in some cases it went, you know, a month and even up to a year. The hours of consultation or the visiting hours were not convenient because most time this coincided with the hours of work, and so it was very difficult for persons to get time off from work to see a physician or to see a health worker. And then there was also problems with the cost, and especially paying high out of pocket costs. Although there is the national insurance or the state-funded insurance, it doesn't cover everything, and sometimes even some of the medication that it should cover may not be available, and so one will have to incur out-of-pocket expenses to cover these. So these were some of the results from the 2013 STEP survey that showed what were the principal or the major barriers to access then. We also conducted facility and community assessment in 2021, and we looked at the disruption of services in 27 public health facilities across Suriname, and the effect of the pandemic. And as you can see, overall, approximately all of the services were impacted and were disrupted. But when we look at, say, services such as family planning, antenatal care, routine immunization, postnatal care, chronic respiratory diseases, chronic diseases, etc. HIV care, there were decrease in service, significant decrease in service volume of these. But what is very significant to note is that during the time, there was also an increase in the demand for certain services. And when you look at, say, mental health services, services to violence and injuries, and the increased demand of, say, services for child care, and also chronic cardiovascular diseases, we saw that there was an uptake in the demand for these services. And this didn't come as a surprise to us, because as we recognize the impact of the pandemic, they put a lot of mental stress on persons, and so there was a greater demand for mental health services to assist persons in coping or to really attend to their mental health needs. But what is very troubling is that there was also the increase in services for violence, and also, as you know, the increase in chronic diseases. We also looked at the percentage of first level of care facilities that considers specific barriers as reason for the drop in the provision of services in the country. And the four important highlighted areas that were mentioned were infection prevention and control, lack of human resources, so that they were unable to offer services, difficulties in terms of financing to continue to offer their services, and the lack of medical supplies being available to them to continue to offer the provision of these services. But a lot of it had to do directly in terms of infection and prevention and control measures being put in place in order to decrease the spread of COVID-19. We also looked at the percentage of informants who considered the community had unmet needs. in the last in the last 3 months, and this was a survey that was conducted by PAHO across 20 facilities, and the areas that were mentioned in terms of unmet needs was, you know, the greatest areas were mental health services, access to care in terms of medication for chronic diseases, laboratory testing, etc. And then we looked at another survey looking at the barriers before COVID-19, and also to identify barriers to access during the COVID-19 pandemic. And the major barriers that came up before COVID-19 were principally geographical access. As you know, Suriname is a country located in South America. There are many communities that are interior and very difficult to access these communities, and some of these communities may be far away from clinics and hospital, and so the physical geographical barrier do pose a challenge in terms of accessing healthcare. But then other barriers such as administrative barriers, the lack of information, people preferring traditional medicine over regular care, lack of quality in terms of the facilities, and so were the main barriers before COVID-19. But during the COVID-19, the barriers that were highlighted were lack of information in terms of how they can protect themselves and keep safe. So even though people wanted to visit a health facility, they were concerned that if they visited these facilities, they can contract COVID. And so they did not have this information to assure them that these facilities were safe. So the lack of information, administrative barriers, they were also fearful of getting COVID-19. So that in itself was a major barrier. The financial barriers, again, in terms of high out-of-pocket spending, and even with COVID-19, many persons lost their jobs, and so there was a prioritizing whether you're going to spend money on healthcare or you're going to really save the money and use it to buy other stuff such as food. And geographical barriers, etc., were all highlighted as significant barriers to access during the pandemic, along with movement and restrictions that were initially put in place to prevent the spread of the disease, and lack of quality in terms of the facilities, etc. And so among the responses, the community informants recognized that health promotion activities, the distribution of information and education materials, and financial and material support to access health services. And so we looked at the percentage of key informants who considered that there was an increase in health or environmental health initiative in the country. And so if you look across this, we see that equally the respondent mentioned that health promotion activities, the distribution of information, the provision of face masks, etc., financial and material support to access to care, recognize that these will support access to health service delivery. The major challenges to reduce and eliminate access barrier in Suriname. We just recently concluded the assessment of the essential public health functions.
Rosemond, excuse me, Rosemond, you have 1 minute, please.
Okay, so I'll wrap up in 1 minute. So so the essential public health functions, across these 11 essential public health functions, we recognize that there is significant work to be done to bring these functions up to the level that we want them to do. We've been working with the Ministry of Health and stakeholders to really increase the capacities across these functions. So institutional strengthening is required for all of the essential public health functions in Suriname. significant gaps that exist are the availability of health information systems, monitoring and evaluation information to guide, a coordinated response. The functions related to the allocation of critical health systems resources are needed. And also when we look at human resources for health, that is an area that needs strengthening, because a lot of times facilities are left without the critical human resources to respond. And finally, I'll conclude by saying that, that the demographic transition continues to lead to an increase in the burden of non-communicable diseases, which is negatively impacting the health status of the population. Awareness of the social determinants have increased. However, there is a health in all policy that is being implemented, and it is really targeted at reducing or eliminating inequalities, etc., but putting health centrally at the response in the country, but it has not been fully implemented. And so the PAHO office is working with the Ministry of Health to push for the full implementation of the Health in All policy initiative. Adequate health financing remains a constraint in achieving universal health coverage. And just last week, Suriname conducted the health financing progress matrix assessment, and this will definitely provide us with some information in terms of where are the gaps, and also what they've been doing well in terms of health financing in support of universal health coverage. As I said earlier, geographic accessibility is a main barrier, and especially in the rural and hinterland communities. The pandemic has amplified the pressure on health systems and its limited resources. And so the current Ministry of Health is going through a reform process, and there's a health reform team that is taking all of these into consideration with the support of PAHO, the assessment of the essential public health functions that was recently concluded, the health financing progress matrix that is just that we've just done last week, but also with support in terms of the technical assistance. We're now implementing a telehealth project with Suriname, and this will help to even increase access to those who are in the rural areas where geographic accessibility is a barrier to care. So the Ministry of Health of Suriname is moving towards the strengthening of the health authority and capacities, through a renewed approach of the essential public health functions. So thank you very much, and over back to you.
Muchas gracias, Rosmo, por compartirnos estos resultados del trabajo en Surinam. La verdad que la información...
Thank you for sharing this work in Suriname. This is valuable information. Now we are going to wait for your questions. To continue with our presentations with the experiences of countries, we are going to give the floor to Dr. Juan Ángel Vázquez, head of the Planning and Assessment Unit of Management of the Health Secretariat in Honduras, who is proposing to address the discussion of barriers for strengthening the comprehensive
las barreras de acceso a servicios esenciales.
addressing for reducing the barriers to health access. Welcome, Juan Ángel. Again, thank you for accepting our invitation. Good morning. I would like to tell you that this is a study that we did with many stakeholders, both institutional and non-institutional stakeholders, with many people who are not maybe now in the Secretariat of Health, but they were actively participating. That's why I am also thanking some previous authorities, colleagues who were involved in this study. As you can see, we want to strengthen the integral, the comprehensive approach to reduce the obstacles to health access. We wanted to identify the main aspects, the areas of intervention, to the analysis of references of data, collected with national surveys, and we did this with stakeholders, with key stakeholders, with quantitative and qualitative analysis, with interview with key informants to have the evidence of availability of references. It is important to mention that the Health Secretariat has had some important milestones in our history. We are now going to mention the most significant milestones since 1998, where we had the state law. We were coming from a military process, military government process. We had two governments before having this new code that was reviewed in 1991 for the transformation of the health sector. In 1994 is also an important year with the Access Program. With this program, we were defining the strategies, national strategies for capacity building and social participation. In 2019, in 2090, we had the legislative decree for a long-term planning and the national plan for 2010 and 2038. We achieved the coverage. We wanted to achieve the coverage at all levels. 2013 is another important year because we have the national health model. It is still in force and it establishes the organization of integrated health service networks. We had many achievements in this period. We improved the access as a consequence, and we also promoted the primary health care with a comprehensive perspective, the strengthening of essential health functions. We also created 20 health regions and the reduction of poverty and the implementation of the national health model. We implemented this since 2003.
We can see in these charts that I will now summarize. We have identified all key stakeholders and the many stakeholders who participated in this study. It is non-supply of medicine and supplies, a lack of staff at healthcare facilities, lack of knowledge on culture, roles, and customs, mainly regarding gender, as we are still chauvinistic culture country, and women need to ask permission from their husband to access healthcare services. Often, healthcare supply is not adequate to the population, and they have restricted schedules. After 3 p.m., healthcare centers are not providing services. Long waiting times for the existing staff, and as I mentioned, limited schedules for healthcare centers. This summarizes the main priorities. This chart is important. If we look to the red bars, which are for 2019, it reflects that 18% of those surveyed reported a lack of money in order to access attention. And this lack of money is also due to lack of medicine because they must pay a ticket to move for more than 2 hours into a health center, and also due to them not being medicine and they need to get money out of their pocket or leave their other children behind, because usually there is 4 children per mother. So they have to pay for childcare, and if she has no money, then she will not have no access. It is important to mention that here mainly what we mentioned, that it is 18 for 0.4% that is mainly reflected in rural population. Next. This is important as we have territorial division into 18 departments, and here we see that the eastern departments in our country, such as Olancho, Colón, El Paraíso in the western part, are those with more difficulties in access, geographical, and also for financial barriers. So these are the departments with poverty levels that are highest. This chart is important because it shows cultural and gender issues, repeating issues for women's access, and the lack of finances have an effect in that for prenatal services, their possibilities are reduced in 20%, and to have a pap smear, it is reduced in 34%. Finding in a healthcare facility reduces in 18% as it is hours away. 23% reduction in possibility to childbirth services, and also family planning is reduced in 23% if they do not obtain permission from their couple. With regards to culture, 20% reduction, the possibility of healthcare for tending to acute respiratory infections, and reduction in 16% to child delivery services, mostly due to cultural issues. Now, what are the main access barriers to immunization? We will now mention some significant landmarks. In 1978, Honduras was signed the proclamation of the 8 essential elements for primary healthcare attention from 1978, 1979, the creation of the program. Another important aspect, apologies, the audio is breaking up, happens later, 2014. Sorry, there's no audio. Apologies. The healthcare staff, the technical normative units, the regions, and the executive units to be able to develop immunization schemas. And apologies, there's no audio again. This is, oh, here. Dr. Vasquez, I believe there's an issue with your connection. Your audio's breaking in and out, coming in and out. Can you hear me, Dr. Vasquez? Yes, can you hear me? Yes, now I can. So the reasons for the immunization schema not being applied according to those surveyed, the first, as mentioned, that there are no vaccines. The second thing is the child is sick, therefore they were not taken for immunization. These findings are of a high importance to reflect upon, analyze, and to make some sort of decision making, as we also need to see that the healthcare services must expand their attention coverage. Something that is important is the percentage of barriers to immunization services, as 33% of individuals mentioned that there's no sufficient availability of resources. When they went into a healthcare center, there was no supplies or human resources, and 26% mentioned that there's little acceptability as well, acceptance to seeking services due to social or cultural issues. We mainly have approximately 9 ethnical groups, and often we all do it in Spanish, and we are a country that is multi and pluricultural, so we need to change our strategies also for indigenous peoples and Afro-descendant populations. The main findings with regards to availability, a lack of medicine and supplies is one of the most relevant. Acceptance is the lack of empathy and a lack of belief in the staff. Regarding contact, there's a lack of information on immunization campaigns, especially via mass media, effective coverage, a lack of coordination and common criteria in the national healthcare system with regards to housing, non-compliance of schedules, a lack of records of prior dosage, long waiting times, and people are not waiting for their own turn. Geographical accessibility, often immunization is hours away, which has further deepened due to a lack of citizen security. Often immunization teams cannot go out to some difficult areas because they are taken by maras and gangs. And another barrier is with regards to out-of-pocket expenditure as government is providing, but this is non-existent as the government is providing immunization. Now, what are the key issues that are cross-to-access issues? The high level of segmentation and fragmentation of the healthcare system, which difficults institutional capacities and political capacities regarding to ruling the system one part of us all. It's important to consider the split between public and private domains, plus social security and the private insurance. It's important to consider related aspects of technical viability and initiatives recently deployed regarding policy. This goes through some political aspects that have stopped, and this has shortened, for instance, processes for primary healthcare attention mainly, and boosting the national model of healthcare. Regarding budget, we're only awarded 3.9% to the healthcare secretariat, and from this percentage, often there are transfers to private institutions, and we only have 2.9% remaining, which basically is only to cover the healthcare staff's wages. What are policy options to reduce and eliminate these barriers? I will only mention the strategies, which is strengthening the ruling duties of the healthcare secretary with leadership that must act on collective action and to strengthen capacities of healthcare services, prioritizing the first level of attention and a model of attention that is focused on individuals, families, and community to develop and implement a strategy for strengthening human resources in healthcare and to increase and improve funding stemming from according or appropriate budgetary planning. I'll mention some issues. We are in the process of creating a healthcare system based on primary attention and strengthening public healthcare attention and also social participation and oversight via a national legislation that is reviewed, and it has after a successful process where many sectors and stakeholders participated coming from the previous government, and currently there's a review being carried out with new stakeholders as well that will be ready according to what has been told by our minister. This will be promoted and it will be ready this year. Another thing that is important is to mention that strengthening primary healthcare attention, which must not be confused with strengthening first level attention, whereby we have more than 1,600 healthcare facilities and 32 public hospitals. There is a process also that establishes to see categorization and functionality and improving according to diagnostics that they currently have. And it is important to mention that if it needs to be done, also the comprehensive healthcare networks that are still being strengthened. And I would like to thank the Pan American Health Organization in Honduras that has provided important support as a strategic ally in order to carry out this dream and to comply to this social duty that we mainly have with the poorest in our country. I believe my time is up now. Thank you so much. I'm available for questions. Thank you so much, Dr. Vasquez, for your presentation and also for your input and remarks. I would like to tell you that we have more than 700 participants at this seminar. I believe it's quite a representative figure. Thank you, and we are now moving on to our next guest, who is Dr. Alarcón, General Director for Healthcare Operations from the Ministry of Healthcare Peru. Dr. Alarcón will be presenting the experience for analyzing access barriers in Peru, focused on its relationship with the reform initiative for the healthcare system. This is why her presentation is entitled Advancements in the Law for Universal Healthcare Insurance for Reducing Access Barriers to Healthcare Services and Challenges Post-Pandemic. Dr. Alarcón is a surgeon and with a mention on hospital care by the Federico Villarreal University, expert in healthcare services by the National University of San Marcos, and school or chartered medical professional. She has broad experience in healthcare services management, with many duties assumed during her career in the healthcare ministry. Welcome, Valentina. Thank you for your participation. Go ahead. Good morning, everyone. Apologies for my voice, but this is an important event to our country and the region, and we would like to share with you results from surveys carried out in our country under support. So we will be discussing advancements regarding universal healthcare legislation, reducing barriers in access to healthcare services, and what challenges we have post-pandemic. Two studies were developed accessing barriers and first-line services analysis. So to know the situation with regards to our reform in healthcare and universal insurance, in the year 1993, healthcare protection is introduced as a right, but there was no government responsibility. In 1997, Law 26842 establishes a co-responsibility of government and introduces the concept of public insurance in segments of the population, child, mothers, and the youth. In 2002, the insurances are combined and coverage expands, and plans are set up for maternity, infants, and adolescents. In 2003 and 2004 already speaks of a law for decentralization, and we also start speaking about beginning a model of comprehensive attention. We speak of networks, micro networks, and also a mobile offering for dispersed populations. In 2006 and 2007, we're speaking of expanding provision and geographical focalization. We have other groups coming in, focused on the poorest segments, and also speaking about those insurances that are semi-contributive. In 2009, with Law 29344, the coverage is expanded to the population, and the PEAS is created, the Essential Insurance and Healthcare Plan, which includes all institutions, public and private, and those complementary plans are defined. FISAL begins a way of funding for high-cost diseases.
In 2013, we have more funding for this insured population. We have also the opening of a targeting program for the expenditure for a public service, and we go beyond these criteria of poverty to go to vulnerability. We are talking about universal access. In 2019, we have more flexible standards with a new regime to include uninsured population with a subsidized regime with poor, vulnerable, and specific populations. We have also a greater coverage, and in 2021, we have the updating of the PES with the incorporation of health care. These are the main milestones in our reform, health reform in Peru. According to the surveys we have in our country, we have these 4 stages. Stage 0, the design and preparation of the analysis. Step 1, data collection. Step 2 is also a systematic literature review. Quantitative data analysis, interviews with key informers. We interview with 22 people. We interview with 36 representatives of the community. And part of what was collected in these interviews with the authorities showed that the main barrier was the economic barrier to have access to health services. Another barrier recognized by our authorities is the economic barrier. We have these financial gaps, and they are essential, but to guarantee access to health care. In the surveys, we see how access was improved. And we see that in the last months, in 2021, we had an increase of some treatments. But in relation to postnatal control, tuberculosis, we had a decrease. In general lines, in the last quarter, according to the surveys, we had an increase for non-COVID diseases. Some results of this survey were targeting the assessment of community needs, perceptions, and demands. 94% of respondents believe that most in the community had unmet healthcare needs. 100% consider that access to healthcare was moderately affected or greatly affected. Of course, there was an increase of financial barriers, administrative and contact barriers. 72% of respondents consider that the majority of people is concerned about the spread of COVID-19. We had fears, and of course, it was general in the population. 30% or more of respondents believe that information, communication, health promotion, and biosecurity activities increased during the pandemic. 16 people in these surveys were in Lima, and the rest in other areas in the country. What are the main barriers that were identified? In orange, we can see inadequate availability, staff and supplies, administrative barriers. This is related to waiting lines, waiting lists, acceptability issues, geographical barriers, access, contact barriers with people. Am I a priority? and also financial barriers. During the pandemic, we had more administrative barriers. We have the fear of contracting COVID-19. This in the population and also among physicians, the financial barriers. Also the inadequate availability or lack of resources, mainly the supplies, the contact barriers in human resources. I don't need, I feel well, recommendations for keeping your distance, and geographical barriers. If we compare the previous situation and the current situation, we see these results. In relation to the response by the population, we see that there is the lack of human resources. This pandemic showed that we lack specialized staff. Also, the capacity for problem solving, the administrative capacity, the limited schedules. There is also reduced of the capacities as part of the perception of the civil society, also the level of first level of care. Some geographical and financial barriers, the budget that is still insufficient. We also review with the ENAU survey, and we see the data here. We see the barriers that were reported during the pandemic in the last years. They increased in 2020 and 2021. We see here the contact factors, the financial barriers, and also important here was the acceptability. Also geographical barriers. When we talk about acceptability, we are referring to the treatment of our staff. And in lodgement, we see the lack of time and the contact by the population, which is not considered as serious or is considered unnecessary by the population. We also had the triangulation of this information by now, the household surveys. We see this information that is similar to the presentation presented by our previous speakers in relation to fear, to lack of trust, the quality of health service units, the availability of supplies. We still lack drugs, we still lack staff, health staff, the long waiting lists, the inadequate times for the service provision, the high cost of the medication, the health insurances that do not cover all treatments. In terms of strategic considerations based on these studies, we identified 5 to improve the communication. We had a significant improvement, but we need to work more on that. The intercultural approach, we need to think more of our rural and remote population. We need to improve our services in the first care level and in critical services. We need to maintain, to reduce the financial barriers. The resource allocation was increased, but it is not enough. We are in the process of improving this resource allocation to overcome this gap. Based on that, we had many efforts in the country in terms of budget allocation. We acquired 964 kits for adult, pediatric, and neonatal care. We increased the critical care between July 2021 and July 2022. And we're also following technical criteria for the allocation of these kits. This year, with the current government and the current management, we have allocated 43 million to strengthen the infrastructure in Metropolitan Lima, in hospitals and healthcare services. We had not had this resource allocation since 2 or 3 years ago. For instance, for the cancer treatment, we have 122,000 million at national level. These budgets were allocated also for the purchase of medication, biomedical equipment, and for expanding the supply of infrastructure. These are some of the strategies that we are developing. And finally, what are we looking for as a country in the framework of the first level of care? We want to be specialized. We have medication, we have human resources, but we want to reduce, to go down to the first level, to solve this with external consultations. According to our reference framework, we have hypertension, we have diabetes, mental health, cancer, minor surgeries, neurological conditions, hypothyroidism. We want to reduce the out-of-pocket expenditure. Our information systems through the administrative processes were strengthened, and it was very important to review the state of art of equipment, of human resources, to monitor on a permanent basis these administrative systems to strengthen the operation of services. A very important thing for our country is the law 31538 to approve supplementary credits, healthcare emergency services. Article 26 and Article 27 to guarantee the increase of essential health functions.
These surveys have been carried out and information analysis in order to strengthen our first level attention under decentralization and comprehensive healthcare service networks. Thank you so much. Thank you so much, Valentina, for your presentation and sharing Peru's experience and results from those two studies undertaken at the end of last year. Finally, for the Dominican Republic's presentation, we have invited Dr. Ricardo Melgen, Director of the Healthcare for the Population Division of the Healthcare Ministry. Dr. Helgen is a pediatrician pneumologist with a master's in public healthcare and healthcare administration. Also has a higher degree in management of international public healthcare policy and sanitation sovereignty. He's also directing the pediatric division for the Children's Hospital Robert Rick Cabral, and professor and masters in healthcare management in 2 universities in the country. Also associate researcher from the National Center for Researching Maternity and Child Healthcare. Welcome and thank you for participating from this seminar. Go ahead. Thank you. It is a pleasure for us to encounter again in this situation. Welcome everyone, and please let me know if my presentation can be seen.
Sí, se ve bien, pero colócala por favor en formato exacto. Ahí se ve
Ahí.
perfecto.
Perfecto, gracias. Bueno,
Thank you. So I would like to thank PAHO for the opportunity provided as country in order to present analysis in access barriers as fundamental input for building a strengthening plan for basic duties in public health care in the Dominican Republic. In the year 2001, through legislation 8701, the Dominican Social Security system is created, which contemplates 3 regimes: subsidy, which comes into force in 2006, the contributive schema, which is enforced in 2007, and each with their own healthcare service plan, pending due to reasons that are not timely to present the 2 regimes, but the third and per capita is differentiated by schema, and coverage establishes rates for services. And in 2015, through disposition 03, the high cost medicine programs came into force. And insurance has been on the rise in the Dominican system of Social Security. Currently, there is more than 50% of the population already covered and insured under both schemas, contributive as well as subsidized, according to indicators as, for instance, public healthcare expenditure in 2019 at 2.6, with regards to GDP, lower in Latin America with out-of-pocket expenditure 42.5 over average, and the relationship physicians, nurses, and hospital beds below average, 19.5%, 6.3, and 1.4 respectively. According to the demographic survey and healthcare survey from 2002, 2007, and 2013, the percentage of population that is seeking healthcare when it needs it has been on the rise for many reasons. Possibility of resolving on their own, they did not consider it necessary, and also for not having the money for a consult or for schedules that are convenient for the patient.
Y bueno, en la literatura, ya los expositores que me antecedieron lo han presentado. Surge de forma más frecuente menciones de barreras de aceptabilidad, como por ejemplo las culturales y las basadas en las relaciones de género, la disponibilidad como la limitación.
With regards to availability, gender, and access throughout the whole country, financial accessibility as high out-of-pocket expenditure, and demographics such as resources in rural and organizational areas. Last year, with the support of the Pan American Health Organization from its office in Washington, as well as in the Dominican Republic, we began a process for evaluation the essential public healthcare functions in the country. And this has come with a process that took more than a year, as it is articulated in 3 phases. And currently we are ending the 3rd phase. But we have analyzed available evidence in literature, qualitative and quantitative information available, workshops with stakeholders for gap analysis in many multidisciplinary workshops, multi-institutional ones, and quantitative analysis for barriers analysis with 9 interviews to key informants. And those surveyed highlighted geographic and financial barriers mainly that are related to a lack of infrastructure in the healthcare resource system. If we look at financial barriers, high out-of-pocket expenses that I mentioned at the beginning, and many occasions they put in jeopardy the financial stability of the population as there's a significant dispersion in healthcare rates, particularly with regards to medicine that is not formulated according to the active principle. Also with geographical barriers where the users must move long distances to access healthcare services, particularly in rural areas, where in some cases they're available 24 hours a day. Also, interviewees told of barriers related to availability, that there are significant limitations in infrastructure capacity and resources, particularly in first level attention in rural areas. Rural areas present limitations in human resources, especially those related to medical specializations. With regards to organizational barriers, there is denial of service, and even those contained in the plan in some cases impose additional paperwork or bureaucracy for access, assignment of appointments too far away in time. With regards to contact barriers, there is there is a lack of knowledge on rights, and with regards to availability barriers, there's low trust or reliability in services due to a lack in infrastructure and quality, and high unsatisfaction with service quality of service. Likewise, these individuals that were the key stakeholders that were interviewed pointed out some structural issues that lead to these access barriers, as for instance, governance in the system, which should be led by the Ministry of Health Care, and which should harmoniously coordinate the sector. In that sense, decentralization can be valuable, but its implementation requires to avoid fragmentation of the system. The many public entities required to develop activities articulated to a single purpose in healthcare. They also propose that it's necessary to uphold an increase in income in the system, as well as increase public expenditure efforts to diminish access barriers. For instance, access to the system with regards to the type of occupation, be it formal or informal. In the labor market, contribution to the system is affected when there's high informality. For example, according to statistics from the central bank and from 2022, the rate of informality is 58.1% and unoccupancy 6.1%. Existing gaps in between per capita differentiated between contributive and subsidiary schemas lead to greater financial access barriers and organizational barriers. On the other hand, it's been proposed that the design and content of plans for services should promote treatment and comprehensive management of healthcare in the population, and the plan should allow integrality in treatment of diseases, mainly those that are chronic, and inclusion to the plan must be based on evidence and the needs of patients, and not only based on complaints and demand from users. Also, responding to short-term criteria, it's important to assess results from inclusion efforts. The Dominican Social Security and healthcare system require unified and quality information at the individual level as well as an aggregate. It has been proposed that the medical history must facilitate decision-making from healthcare staff, favoring continuity in management and avoiding regression. Measures are necessary to tackle underreporting of statistics in the healthcare sector. This must lead to decision-making in governments in healthcare. Likewise, these informants proposed as structural issues that led to access barriers that must be strengthened, the strategies in the system, as well as acknowledging efforts in strengthening primary healthcare attention. Sorry, the audio is coming in and out. Efforts must be focused in diminishing barriers. Enrollment must not turn into another barrier, and it's necessary to strengthen activities and strategies in public healthcare that are across to the unified social security system, which entails strengthening capacity to respond to the needs in order to attain optimal healthcare results. High levels of technification are required at all levels of the system. Also, adequate supervision and control is proposed, and service provision must be essential, which requires to control and avoid denial of services included in the service plan due to administrative reasons and those related to the rate. Service provision and ensurement must be strengthened in order to reduce access barriers. And lastly, they proposed that quality must be present at all levels of the system, planning as well as service provision, which makes it necessary to align systems from providers to perform adequate risk management. The public sector is often associated to less satisfaction on part of system users, whereby this requires strategy which favors efficiency and quality in these institutions. Healthcare risk administrations respond to risk in the system, and their assessment is done via a component associated to quality and optimal results. Along those lines, and considering the assessment process of essential roles, some policy opportunities are identified according to the policy cycle in order to reduce access barriers and to strengthen basic roles in public healthcare. The assessment part, it is proposed to identify minimal criteria for the many subsystems for monitoring and assessment to improve compatibility and connectivity of the many sources of information, utilization of information produced for policies and programs, strengthening mechanisms to ensure effective participation and empowerment of the community in monitoring and follow-up to improve productivity, analysis, and use of information on social determinants and barriers in access to service utilization, including satisfaction, and strengthen reporting mechanisms for information at all levels, and to perform studies on the needs in healthcare for service plans, as well as sufficiency of per capita for every. In the development of policies, it is proposed to strengthen leadership of the National Authority of Healthcare in formulation of legislation, monitoring, and follow-up, including its relationship to the legislative branch, as well as updating national goals for healthcare priorities at the sanitational situation to strengthen and expand structures, resources, training, and periodicity effectiveness of social participation and accountability, tending to observations from bodies of human rights with regards to healthcare, be it migration and voluntary interruption of pregnancy and LGBTI populations, and to review formal mechanisms for guaranteeing exercising healthcare rights, strengthening regulatory frameworks for processes, procedures, and control and supervision, as well as establishing strategies that strengthen services of healthcare in remote areas such as rural areas. Allotment of resources contemplates to designing strategies for human healthcare resources as planning needs, tending to the needs in order to improve the needs, improving strategies for working with other entities with regards to collection, assignment criteria, and reducing out-of-pocket expenses in healthcare, to strengthen technology for healthcare as well as medicine, and capacities for centralized purchases and strategic resources, provision of generic medicine, to strengthen available resources in the system and to include quality criteria for payment of per capita, and lastly, and access policies to update the access policy with incentives to quality and attention and equality, and to strengthen addressing primary healthcare and priority programs in the country, to contribute to a comprehensive strategy and healthcare attention, to strengthen a promotion of healthy environment, water quality, basic sanitation, avoiding risk factors such as reproductive, sexual health, exercise, and reduction of violence, to strengthen addressing disease in all levels of policy via intersectorial articulation, and to establish a unified medical history which facilitates adequate treatment and ensuring of health care. Thank you so much.
por su atención.
Thank you for your attention.
Gracias, Ricardo, por tu
Thank you,
presentación.
Ricardo, for your presentation.
Para todos los
I would
panelistas.
like also to thank all the speakers.
El tiempo va pasando.
You know, time is limited, and now we are going to
Espacio,
have a brief
pero
Q&A session.
cambiar la modalidad.
But here we are going to change our way of working. We are going to have one general question
Panelistas,
for
por favor.
each speaker. Please,
Hicieron su intervención. Empezamos con,
according to the order of their presentations, we are going to start with David.
repito, aplica para
We have the following question. This goes to any participant, any speaker.
cómo
The question is,
avanzar
how can we continue working in measuring the barriers, and what
para avanzar
actions we need to prioritize
a
to
la salud en una
achieve the right to health
Así que,
in
por
a
favor, en el orden,
EPS
empezamos con David.
approach?
Si
David,
todos
please.
me escucharon, sí, la
I don't know if you were all listening to my question. I'm going to repeat this question. How to continue moving forward in the reduction of barriers, and how we are going to work in the EPS approach in the health service provision. Please take no longer than 2 minutes.
Medir estas brechas entre cobertura y acceso
These gaps
realmente
between coverage and effective access, we need to see clearly and to review studies that address the different access barriers. As we mentioned in the different presentations, these barriers, they have different characteristics. It also depends on the characteristic of every sector. It is also very important to do these measurements on a regular basis to then be able to have an accurate diagnosis on public policies that can allow the exercise of the right to health. And this should not be a business. Health should not be a business. There are always private, the private sector, clinics, or the industry, and we need it to be either public or private. There is a complex situation in terms of health service provision, and also in terms of centralized service supply procurement. We cannot have an effective access if we cannot have an adequate management to guarantee the sustainability of our health systems.
Muy bien, David, gracias.
Great, David, thank you. Rosmond, please, we give you the floor.
Thank you very much. I think that what we need to do is that we need to use the evidence that is available and to continue looking for evidence in terms of what are the barriers to access. But also what we need to do is that we need to also focus on community and let community be the center of the delivery of healthcare services. And so putting community at the center and understanding what are the needs of the people, understanding what are the barriers to access, then we can work in terms of addressing these. But we need to understand, we need to collaborate, and we need to move forward, leaving no one behind. Because if we move forward, leaving the vulnerable, the disadvantaged behind, then we're not solving these problems, and these problems are going to continue. So I think that we need to really collaborate on governments, communities, and even ministries of health, etc., working together to find ways in addressing these access barriers. Over.
Ok, gracias, Rosemont.
Thank you, Rosemont. We are now going to go to give the floor to Jose Angel, please.
Buenos días. Sí.
Good morning. Yes. We have a great opportunity because we are now in a transition period. We are changing governments, and we are in the development of the preparation of the government plan. We are then going to have an influence as health secretariat, for instance, in barriers related to time, to culture, and also we need to work on education. We are a country with a high level of education. And we need to have these government strategies in our institutional strategy. The main barriers are the geographical access. We need to locate the new health centers in places where they can have the services close to them. And the other thing is primary health care. We want to have these health services focusing on the primary health services. And for this, we also want to develop the vaccination programs. We had a low coverage after having 95% after the pandemic. We are a vulnerable country, and now we are at the percentage of 72 in terms of vaccination. Some health programs were removed in the past, and we are rebuilding these programs. Thank you.
Valentina, por favor, tu turno.
Un poco para poder darle continuidad a este tema de disminuir las barreras.
I would like to continue with the topic of reducing the barriers. With the information that we collected, we were able to make different decisions to strengthen administrative systems for the operation of services that we are monitoring, and also to strengthen and improve information systems, our current information systems. We also want to reach specialization in the first level of care, and for this we will have new regulations or the updating of the regulations. Another thing is that we want to continue promoting the networks of critical services, the networks of diagnosis, the comprehensive networks of health, and the most difficult, I think, is to change the mindset in our staff to improve these human resources from a different perspective, to motivate our human resources and to work closely with them. And obviously, we also want to guarantee adequate spaces for the care of our patients, for our own staff, and also to guarantee the supplies. Thank you, Valentina. Finally, Ricardo, please. Thank you. As I was showing in my presentation, we started this assessment of essential public health functions last year to identify also the access barriers. And we were able to collect a lot of information. The country is now preparing the health plan. In the Congress, we are also discussing the formulation of the social law. So this is the result of this review and assessment of essential public health services, and we need to have this outcome, this evidence, these guidelines to strengthen the primary health care and to strengthen also the general the general health services. All this information should be translated into evidence, into working plans, and also into information for decision makers at the Congress level so that they can have appropriate information for reviewing the health rules. Thank you, Ricardo. We would like to thank all participants for your questions. We would like to have more time to address them. We would like also to thank our speakers for their presentations, their comments, and their answers. Before closing this seminar, we would like to remind you that the recordings of this event and the materials are going to be briefly available in our website. We are going to share the link with you on our chat. To close this event, we would like to invite our director, James Fitzgerald. James is a PhD in pharmaceutical sciences in Dublin University, and he has more than 20 years of experience working in PAHO. He is also the author of different papers on his domain. James, welcome. Please, you have the floor. Thank you now. Nice to see you, dear colleagues, and also the representatives of the Ministries of Health, dear speakers, colleagues. It's a pleasure to be with you participating in this session that was very good, that was very intense, and where we see some working lines that need to be strengthened to move forward and to solve these barriers that were presented in this webinar. I would like to highlight some topics related to the resilience in our health systems in the Americas and the barriers that we saw in the presentations. Since we started with this series, we were discussing about the different aspects the region needs to strengthen to have resilient health system and to protect the progress already achieved and to move forward to universal access to health. It is clear that what we saw today, the barriers, solve the barriers is a requirement to achieve universal access to health services and also for sustainable development. No doubt the content of the presentations that we saw, the results of the analysis of the barriers, and especially the view of the future is key to strengthen our health systems, starting with the elimination of the barriers and the problems that hinder the access to health services. I would like to close this presentation, this event, with some key topics for PAHO that are common items in the presentations that we saw. First of all, the population has sometimes more services than problems. And our doubt is, how are we going to continue measuring the barriers to eliminate them and to structure the public health the policy?
First, in homes that allow us to get information on the magnitude, the scale, and duration, and also along with this, qualitative data from analysis upon understanding for each access barrier at the country level. This really reveals the importance of these mixed methods that the countries need to develop to study those barriers that persist, which pretend not only to analyze the starting point, but also to characterize problems in access in light of policy options derived from interpreting the journey of the healthcare system with regards to the barriers. So the main matter for the seminar, and on that, allow me to put forth some further remarks. In accordance to what has been presented and that we've seen from aspects that have been presented, there are patterns in terms of multiplicity of barriers. There are also different outlooks in the countries which require differentiated responses. For example, the geographical barrier in rural areas and remote areas in some countries, such as I've seen in Suriname, access barriers have exacerbated during the COVID-19 pandemic. This is very clear. And in some cases, this has entailed significant regressions. In the 5 cases presented, the scale in access issues in all persist inequality levels with regards to how the population with most vulnerability is experiencing these barriers. Problems in supply, these are common elements that seem difficult to address and to reduce. Therefore, they require greater efforts from countries. Likewise, barriers regarding acceptance, so the lack of trust and cultural and gender aspects are quite prevalent, and they affect mainly those populations that are most vulnerable, those poor or ethnical groups, and they require, from our perspective, a comprehensive treatment. Efforts for improving insurance have had very positive results in terms of reducing financial barriers in some cases. These issues persist and affect the poorest, and in some cases, this has become more acute under the pandemic. So we need a call to action. These barriers that the population is facing have much to deal with the performance of public policies, and in particular, we need to learn from different experiences, which is one of the reasons for us being here on a monthly basis in these seminars. From PAHO, we believe it is fundamental to facilitate these shifts and to contribute to efforts in our countries to strengthen standards addressing access issues. We will continue supporting many assessment processes then and strengthening of capacities in sanitation authorities. We are doing so through essential roles of public policy renewed in us delivering analysis and access barriers, capacities and leadership, ruling and governance of sanitation authorities play a key role in efforts to transform systems and to reduce barriers. And authorities are called to call for collective action, which includes all other government and society stakeholders in order to advance toward healthcare systems focused on primary attention. Third, to strengthen capacity of networks and healthcare systems to expand access. And lastly, to expand and sustain public funding for healthcare and social protection. Before ending, I would like to also highlight the role that many stakeholders from society have had in the process of analyzing the barriers in the presented cases, and especially in spaces of discussion on policy options. Social and community participation is a principle that really crosses many mandates in organization and efforts that make it really effective. Operationalization must continue and strengthen. A new generation of transformation processes and strengthening of the healthcare systems must bet in generating participation mechanisms in society that are real, deep, inclusive, and accessible, with a perspective on diversity in order to guarantee full exercise of healthcare rights. This will be the topic for our next webinar that we would like to invite you to on November 11. Dr. Karasetian, our organizational director, will be with us then. I would like to thank you all again for your participation. This has really been a deep discussion, and again, gratitude goes out to all our panelists and of course the organizational, the team that set this up. Thank you so much. Thank you, James, for your words and your reflections are really so important. And I would like to invite you to our next seminar in November. I would like to reinstate gratitude to all our participants, panelists, all of the organizing team. And well, I would like to wish you an excellent day. We will meet again in the next seminar. Good morning and good evening according to your country.